the main mandate is bring them to the hospital with a pulse, right? Bring them to the hospital with a pulse. Patients that have clear cardiogenic shock, you look at the EECG, there's a STEMI in there. Their JVP is at their ears, right? They're frothy, they have pulmonary edema. Then in those specific patients, I would actually not give fluids. We're biased in that we want to save everyone. That's how we were trained. What do you mean you don't want this? We want to save everyone. They call you for a patient who has complete heart block, heart rate of 30 beats per minute. And the hospital is an hour and a half. And the ambulance is not even at the hospital yet.
We could talk about all these options and medications, but what can you deliver to the patient in the moment? Do you think we could pivot to what to do when things start going wrong? So we talked about, managing it and preventing it, like long term, but I understand you've done a good amount of research on managing cardiogenic shock as well, right?
Right.
So currently in the pre-hospital setting for advanced care paramedics, our management of cardiogenic shock is, centered around the fluid therapy to a degree and the dopamine as our primary vasopressor medication. So what are your thoughts of like that medication? And then what are, better medications to be giving to these patients in extremis?
Right. Yeah. Cardiogenic shock is bad news.
Yeah.
Right. It is bad news. Like, of all the conditions, I wouldn't choose to, even if pressed. The survival in cardiogenic shock is one in two, right? And we remind ourselves of that because sometimes no matter what you do, the patient will die, right? The patient will die. Now, what has been shown to improve their outcomes is that if you need pressure support, there's more data to support the use of norepinephrine over dopamine. The use of norepinephrine over dopamine because it is less arrhythmogenic. Can it cause arrhythmia? Of course, we've seen it all the time, but less than dopamine. So that's why. In the pre-hospital setting, the main mandate is bring them to the hospital with a pulse, right? Bring them to the hospital with a pulse. So as soon as you hand them off, now the role is to identify the cause of the cardiogenic shock and initiate immediate treatment. So if the cardiogenic shock is from a massive myocardial infarction, STEMI, they're going to the cath lab as soon as they step in the emergency department. Sometimes they pass just directly to the cath lab. Now, if cardiogenic shock is related to the progressive heart failure. So a patient who has non-ischemic cardiomyopathy, say they have heart weakness from non-ischemic causes, so not from blockages in the arteries, and now they have progressed to this state where they are not perfusing to their organs, then they develop cardiogenic shock. Now those patients, you need to define their hemodynamics, meaning they come in because their blood pressure is low, and you need to know what is the main driver of that. Is this a weakness in the heart? Low output? And so when we do right heart catheterization, or the Swan-Ganz catheter, it gives us that answer. It tells me how much output are we getting from the heart, how much SVR, or the systemic vascular resistance, how much squeeze in the vessels, and how much filling does the patient have? Like, are they wet? Are they volume overloaded? And so guided by the right heart catheterization, you can then decide and adjust your medications. Now, even with that, even using this, you don't save everyone, right? And so now you need to decide on what is your exit strategy. What's your exit strategy? You started Dobutamine. Dobutamine is an inocro medication that gets the heart to pump harder. And you started that in response to the fact that the cardiac output is very low. The patient is not doing very well. Now you need to ask, is this patient a heart transplantation candidate? And is this patient a what we call a VAD candidate, or the ventricular assist device? And the decision depends on some factors related to the heart function, the right heart function, the left heart function, the pulmonary pressure, the pressure in the lungs, but also factors related to the patient. Because if they have in the stage a kidney disease, and they have maybe liver cirrhosis, and they have diabetes with endocrine complications, then they will not benefit from a new heart, right? It will just fail because their other organs are failing. And so it's important to put that into context. So I would say in the pre-hospital setting, bring the patient to the hospital, support them with levofed if you need. When you come to the hospital, then you obtain an accurate assessment of their hemodynamics as soon as you can and treat the cause of the cardiogenic shock. Medications are failing. You really want to think of what is my exit strategy. Are we going for a VAD? Are we going for a transplant? If you don't know, maybe we don't know, then are we going to a temporary support devices like intra-aortic balloon pump, and a small balloon that they put in the aorta that deflates when the heart is pumping. So that's almost like a sucking mechanism to get more blood out of the heart, and inflate when the heart is relaxed and closed so that it pushes some blood back towards the coronaries to improve their perfusion. And so sometimes you don't know if the patient is a candidate. You still need more information. This patient has never been there. They say they have no past medical history, but they've never seen a physician. Now you have to start searching for their other comorbidities, and you need to buy yourself time. That's when you get temporary support devices to stabilize the patient while you collect more data and get better sense of the patient and back.
Because I'm thinking, look how nuanced cardiogenic shock is again, and everything you have to weigh and benefit. You have to hear what you're saying correctly. We need to get them to the hospital, but alive. That's already ahead of the 8 ball, already horrible prognosis. So we should try fluid therapy. So we'll say our medical directive is 10 mils per kilo to ensure they have enough perfusion. That if we need to give them dopamine to perfuse their vital organs, they will have a better outcome, hopefully, if we try to optimize their map and everything.
Actually, empathize, and I have a lot of respect to people that look after patients outside of the hospital and assess. Because when they come in and I see them, I at least have 4 or 5 diagnostic tools at my disposal right away. I know their labs, I've seen their ECG, I know their story, right? Everything that happens in the field, you have documented it. So I put that in, and we put the SWAN, and we have the right heart catheterization. So the answer I give you is based on knowledge of all of these 5 diagnostic factors. Patients that have clear cardiogenic shock, you look at the ECG, there's a STEMI in there. Their JVP is at their ears, right? They're frothy, they have pulmonary edema. Then in those specific patients, I would actually not give fluids. In fact, in those patients, I would diurese them. And if norepinephrine is available, I would use it to support their blood pressure. But if it is not, then I would just use what you have. And the benefit of dopamine, I think, it's already mixed. So you have the bag right there. And the other benefit of dopamine is that if you have a patient who's in cardiogenic shock who has bradycardia, right, who has bradycardia or complete heart block, we have a lot of those in Kingston. We have older patient population on their electrical wires get old too, and they fail sometimes. And so those patients, dopamine can help because you're augmenting the heart rate, which will improve your output right away. So that would be the mandate of the pre-hospital assessment. Once they come in, now we have gathered more information, and we can then institute therapy that are more targeted to the patient hemodynamic.
Yeah, definitely. We're following the Forrester classification is usually what we're taught how to manage these patients. And for the, cold and dry patients, we'll give a little bit of fluid, then we'll go with dopamine. For the cold and wet patients, we'll go to dopamine and, different other approaches there. So we're definitely not like fluid loading patients that have high of course. But yeah, so you mentioned Dobutamine you use more in hospital, and you did some research on comparing Dobutamine to Milrinone. Yeah. What are your thoughts on managing those 2 medications, or, is there a different patient population that you choose the different ones then, or?
Yeah. It's such a good question. So just to give a background to the listener. So when you are managing a patient with cardiogenic shock and you did your right heart catheterization, so you measure by right heart catheterization, we mean you put that small catheter across the internal jugular vein down to the right atrium, to the right ventricle, and then to the pulmonary artery. And then you keep going with a balloon tip, so you're not hurting anybody. And then with it all the way until you wedge. meaning you can't go any further. When you wedge, then the pressure that you're getting in that balloon is equal to the pressure that you have in the left atrium. So this gives you an assessment of the filling pressures and of the cardiac output. We use thermodilution, meaning you get a cold saline and you inject it, and then the thermistor, the monitor for temperature, estimates the cardiac output based on how fast that cold saline reaches the thermistor, how fast. And so it gives you an estimate of the cardiac output. If you detect that their cardiac output is low, now you pick your favorite to start taking them for cardiogenic shock. And so the two that we have now is Dobutamine and Milrinone. In Europe, they had levosimendan. Levosimendan, we don't have that here, so it's out of the question. Now, in the past, we thought that there was some misconceptions. So we thought, well, Dobutamine is good. Milrinone is good if you have an atrial fibrillation because it doesn't cause arrhythmias, and Dobutamine is not. And so there was some debates. And I remember when we were running the trial at the Heart Institute in Ottawa, I myself was feeling bad about, how can I randomize this patient when I know that he will benefit from Milrinone? And so Dr. Hebert, Ben Hebert, his name, he's in Mayo Clinic now, but he used to be at the Heart Institute. One day we sat together. He said, "Oh, you're saying show me what like based on what?" And I look up the literature. There's nothing that says that, oh no, patients with AFib do better with this, or patients with pulmonary hypertension do better with this. So it is really hard to and so the trial was negative. The trial, meaning they were equivalent, right? They were equivalent. So what do we do now? We use what the nurses are familiar with.
Okay.
We use what the nurses are familiar with, because I know, the effect of the drugs and how much to give, like the dose. I know how to mix it. I know how to put it in the pump and the micro dropper and the macro dropper and how to program this. I have no information at all. If you give it to a nurse who also is not familiar, then that's a crime. But if you use something that is very familiar to your local setting, your outcomes are likely going to be better. So really more of the administration, the comfort of the user. But in the trial, there was really no superiority of either.
So we obviously come at this from like a pre-hospital kind of resuscitation lens. And I just wanted to talk about these two medications because, in the future, maybe,
yes,
which my understanding is Milrinone is not very titratable kind of in the moment, right? So you give a dose and then it kind of hangs around for a while. So if you give a dose and then your patient gets worse,
right,
you might end up in a tricky situation. So it seems like Dobutamine might be a slightly more accommodating agent for that setting.
Very good point. Good point. Yes. So the half-life of Milrinone, is 4 to 6 hours. You give them the wrong medication and then now you start 4 to 6 hours. And the other issue with Milrinone also, we don't do this here, but in many centers, they actually bolus Milrinone so that you can achieve that effective dose right away. And so I can understand why in the pre-hospital setting, Dobutamine may be more favorable. Now, we remember, the problem with patients with cardiogenic shock is that they don't come in with one issue, right? No, they're not making it easy, right? So they have weak hearts, so they have low output, but many of them have also very poor vascular resistance. Very poor vascular resistance. So the vessels, initially, they squeeze, right? Initially, they squeeze as a compensating mechanism, but in end-stage cardiogenic shock, you get vascular exhaustion. The vessels give up. And now they're vasodilated, their blood pressure is in their boots, and they have low output. If you give those patients Dobutamine, their pressure drops even further, right? And so that's why I started by saying that, it's easier for me because when we see the patient, we have access to more diagnostics. So I know the ones that have the vascular exhaustion end stage, that I would be cautious to introduce Dobutamine until I build Levofed in Norepinephrine, as opposed to the one that is an earlier cardiogenic shock where Dobutamine is going to save their lives, right? To the point that you look at the chart, a patient who's just been managed for cardiogenic shock early, and there's nowhere written cardiogenic shock, decompensated heart failure improved with Dobutamine. Like if that people recognize it as, oh yeah, that's just one treatment. Now it's important to mention the cardiogenic shock because it profiles this patient as a higher risk, right? Even if I rescue this patient from cardiogenic shock, I gotta have a plan to prevent this from happening again, right? If it is caused by ischemia, then revascularization, obviously. But if it is from progressive pump failure, then we're having the serious conversation about heart transplantation, about VAD, or about palliative care, right? It's not always that, look, we're biased in that we want to save everyone. That's how we were trained. What do you mean you don't want this? We want to save everyone. But it's important to realize that for some patients, they live a good life and they do not want to go through aggressive measures. And so that's also another exit strategy. So cardiogenic shock, very important to recognize it, to name it, and then think of your patient and how can I prevent this from happening?
We were talking about Norepinephrine on the way over, actually. One of the big barriers for us in the pre-hospital setting is needing pumps. You don't to operate Norepinephrine, and that's why we have Dopamine partially, because it's titratable, it's premixes.
Yes.
And it's just interesting hearing physicians' perspectives too on pressors. Like, you almost play this game with yourself, risk benefits for each of them, and it almost becomes a reluctance to give it sometimes. I can say that in the pre-hospital setting, mild to moderate reluctance to give it, but there's a consequence if we don't get it.
That's it.
And there could be a consequence if we do get it, arrhythmogenic events, right?
Right. No, look, you have a good point there. So when I was training in Ottawa, as a cardiology fellow, we were receiving outside calls. So and the Heart Institute had a coverage of 1.5 million people catchment area. And so I was getting calls from other smaller hospitals. And that's when I learned really the power of dopamine, because, they call you for a patient who has complete heart block, heart rate of 30 beats per minute. And the hospital is 1.5 hours. And the ambulance is not even at the hospital yet. This patient needs a pacemaker right now. They tell me, I have two beds here and one monitor. What do you mean pacemakers? They can't, right? And so that's where dopamine. Because there is another medication that we use at the Heart Institute, and we use it here too, isoper. The other name is isoproterenol. Oh, it's great. Beta-1, selective, can increase their heart rate. Yes, but they have to mix it. They have to know how to do that. They have to use a pump. We have no access to any of that. And so that's where we really started using dopamine for those patients. It has very good chronotropic effect, so it'll augment their heart rate. It has a good pressor effect as well. And I think in the pre-hospital setting, it's really more of stabilization mandate, as opposed to when you start, being fine-tuned and selecting medications in the hospital.
You bring up a really good point there. It's really all about the logistics of, we can talk about all these options and medications, but what can you deliver to the patient in the moment?
Exactly.
So I think, that's where it fits within the practice quite well currently.
Exactly. And if you give it long enough, you'll have arrhythmias, right? But think of how many patients you saved, right? So think of how many patients you saved, and side effects and complications are bound to happen. It's very hard to dissociate yourself from being the proximal cause of this, complication. But it's just part of the process, right? It's part of the process. So as if dopamine does have an increased risk of arrhythmia, but when it's the only use, I'll use it, right? I'll use it with no hesitation.
And that goes back to multiple points, how we want to save everyone. You had this disease process is so advanced and so complicated. We're on an 8-ball.
Right.
And even if we don't achieve the best outcome we think we did, you're still doing something by getting their women and getting them to the hospital relatively stabilized.
Exactly. I think that's really important to remember. And I think sometimes I don't know how, and maybe you can actually elaborate on this, is how do you debrief after you become this sick end stage patient and you take to the hospital? Because when we lose patients, and we do, and it happens, then we meet together as a small team that were part of the resuscitation, and we debrief and we talk about this. And I found it quite useful because it's a difficult process to go through. And maybe you can tell me about that.
What are your thoughts on that? It's funny, we talked about that recently, and the culture's getting better, because I'd say historically and just anecdotally, that wasn't too common, but now it seems like it's trending towards let's debrief, because it's big in every other healthcare sector and every other industry. It's
Absolutely.
let's learn.
Yeah.
We didn't achieve the best outcomes. What can we learn from this and gravitate towards it? I think people are going towards that because one, it's a de-stressor.
Exactly.
And you can feel the guilt people have.
Exactly.
But yeah, I think it's just sitting down and having a casual conversation, saying like, hey, what went well? What can I change? What can I learn?
Right.
Because the best learning I have ever had is just talking to people.
Exactly. And you can be surprised by how much some of your colleagues, sometimes you yourself, were holding of that self-blame. I should have done this. No. There's actually absolutely no reason why you would have done that other thing. It's just the patient was sick and they got it, right? And so it was quite an eye-opening.
I think with a lot of these cases, when we manage them, we're so far behind the 8 ball, right? We have a patient with cardiogenic shock, and we don't have a lot of the information. So we're just pulling the trigger on therapies and trying to see what works while we're also moving toward the hospital. But I think like the debriefing with our partners saying, I think we did a really good job. We hit all these, high yield points. And it just turns out these patients are extremely ill. 50% mortality rate in a critical care setting in a hospital.
Exactly.
So I think, preparing for those cases so that at the end of the day, we know that we did a good job with the tools that we had. I think that really helps as well.
I agree. 100%.
So we got to be mindful of time because you got another talk. Yeah. Is it okay if I leave this personal question? Because I think this is so cool. You can tell how authentically passionate you are about cardiology. What's your recommendation for people to find that? Because you can tell you love coming to talk about this and helping people. How did you find that? How can they find it?
Oh, thank you so much for the kind words. I'll make a plug for my labs. But this is not, we didn't, plan this, but honestly, it is so satisfying to get to work with like-minded individuals, residents, trainees who are interested in cardiology. So my lab, I have a few learners that, and it's so satisfying to see them learn and grow. I think we're very fortunate. I think we are very fortunate that we work in a field that we like and we love, and seeing the impact of your intervention right away, but also having the ability to follow those patients long term. I have patients I treated for cardiogenic shock 3 years ago. They still come to my clinic, right? Not in a gown, or they come in with their spouse, their kids, and it's just so satisfying to see the impact of what you have done and the ability to follow it long term. I have a lot of respect and appreciation to people that work in the emergency department, and like people like you, where you work, you resuscitate someone and then they go, right? And it's hard sometimes because, well, where's the closure, right? What happened to that patient? What about, in a year later, 2 years later? I have patients that I screened their kids for heart disease, identified them, and now they're my patients too. And that just makes us, that just makes our work so fulfilling.
It's contagious. Well, thank you so much for coming on. We really appreciate this. You're welcome back anytime. I'll come to you anytime you want. I know you're busy, but yeah, this has been fantastic. Where can people find you? Or like, if you want to review your research and all the incredible work you're doing.
Oh, thank you so much again for inviting me. I enjoyed this, and I look forward to working together. We didn't get a chance to talk about your, thesis and the work that you have been doing. We talked about it offline a bit. I work at Queen's University. I have a research lab. And so if you look me up at Queen's website, you'll find a small synopsis of what I do. And I have health sciences students that are doing their longitudinal research courses with me. So that's another way if people are interested and they say, you know what, I'm not bored listening to this. It's not bad. I could probably, spend my summer doing some research. And then yes, please, join me there. And then, look into the community paramedics. I watch for the programs that we're building with our community paramedics colleagues, because I think we're just starting. We are just starting. It's a shared mandate. They are as excited about this as we are. They have been, come to the heart function clinic working with us. So I think you'll see more in that setting too, that people will learn more about managing heart failure in the community.
Absolutely. Amazing. Thanks so much, Ruud.
No, of course. Thank you. Thanks for having me.
This channel and its content are created independently and not affiliated with or endorsed by any employer, agency, or organization. The information provided is for educational purposes only and should not be considered medical advice. Viewers must follow their local paramedic guidelines, clinical standards, and applicable laws when providing patient care. Always practice within your scope of practice and seek direction from authorized medical oversight when required.